Welcome everybody. Delighted to welcome you back to the 23rd UCD COVID webinar series. My name is Fiona McNicholas, child psychiatrist, and I'm co-hosting this with my colleague, Dr. Blona Gavin, the College of Psychiatry in Ireland. And we have been delighted to have been supported in UCD by Mr. Paul Harkin. And very regrettably, but delightedly, Paul is handing over that mantle to Noreen Silaji, who's going to support us with the admin side of it. So thanks again to everybody for joining. It's amazing to think that we're now back in level 5 of lockdown, with numbers continuing to increase, although hospital admissions and deaths, fortunately at the moment, not rising to the same extent as before. And it's about 7 months since we went into the last lockdown on the 12th of March. So I do hope everybody is feeling okay, that everybody is continuing to balance both work and home and relaxation and staying healthy. And we are delighted to be able to contribute in a small way in UCD by providing up-to-date, ongoing psychoeducation around COVID in relation to mental health very broadly. You're familiar with the chat function at the end. Please do send any questions you have for our speaker, and also alert me if you would like to join the conversation at the end orally, and we can unmute you, and delighted to do that. I'm delighted to welcome today our next speaker, Dr. Jonathan Rogers. And Jonathan is a Wellcome Trust Clinical Fellow in the UCL in London, and is also specialty registrar in training in the Maudsley. And Jonathan, we're very, very excited because there's beginning to be a little bit more of a trickle of neuropsychiatric aspects of particularly severe COVID. And we're very much looking forward to your presentation today, which aligns very much with your overall research in the biological aspects of psychiatry. So passing over to you, Jonathan, and thank you.
Brilliant. Thank you so much. It's lovely to be with you. It's my first time in Dublin, and it's, yeah, been very much looking forward to it. So thank you. I'm going to talk about the psychiatric and neuropsychiatric consequences of coronavirus infections for those people who are actually infected. Obviously, the pandemic has massive ramifications for all kinds of people. But we wrote this systematic review and meta-analysis quite early in the pandemic to think about what might coronaviruses do for people who have severe infections. We published it in Lancet Psychiatry back in May, and it already looks horrendously out of date. So I'll be presenting some of the results of that, but also some of the ways in which the literature has developed since then. I'm going to talk a little bit about coronaviruses and give some context for them, discuss why we might be concerned about their effects on mental health, have a look at our literature review and what we found happened acutely with these infections, and then what is increasingly becoming important as we look at the longer term impact of this pandemic. What might be some of the longer term impact of coronavirus infections? And we'll discuss some of the implications of this. So coronaviruses have actually been around with us for a very long time. They affect all sorts of animals, including bats, camels, and rodents, but they also have infected humans. And there are 4 common forms of coronaviruses, so the HCoV229E, OC43, HKU1, NL63, all these really catchy terms that together account for about 15% of the common cold. But they also cause about 30% of the respiratory infections, the viral and respiratory infections that sometimes result in older people being admitted to hospital in the winter months. So this was the background prior to 2000. And then since 2000, we've had 3 waves of severe coronavirus infections, which have really focused attention on these viruses. The first was the severe acute respiratory syndrome, SARS, which broke out in Hong Kong in 2002, 2003. Infected a couple of thousand people. The mortality rate was about 10%, and was eradicated. MERS then occurred in the Middle East in 2012. This is the Middle East respiratory syndrome. another coronavirus, and in many ways it was even nastier. Again, so for both SARS and MERS, bats were thought to be the origin, but with MERS it seemed to be actually spread by camels. What's been interesting about MERS is that it's got this awful mortality rate of 30%, and it affected fewer people initially than SARS, but it's never been completely eradicated. And there have been a few waves affecting a few people that have cropped up ever since. COVID-19, as we're all well aware, is caused by the SARS-CoV-2 virus and has a lot more similarities to SARS than it does to MERS. Obviously, it started in 2019 and has spread around the world over the last few months. Coronaviruses in psychiatry have a history going back before the current pandemic. One group in the States with Bob Yolkin have been investigating the effects of various prior infections on mental health. Their design has been a case control studies. So they've looked at patients with severe mental illnesses and healthy controls and compared the prevalence in those groups of antibodies to certain infections. And for our purposes, they've looked at a number of common coronavirus subtypes. So these are the ones that usually cause the common cold. And they found that the HCoV NL63 infection in the past was more common in those with more mood disorders. And in people with psychotic disorders, the HKU1 infection and NL63 infection were more common, which is interesting, but of course, we don't know what's happening there with the causality. Maybe it's people with severe mental illnesses who are more likely to contract these infections. And we don't know the longitudinal course of these. But it does mean that it's an area worthy of our attention as psychiatrists. So why might we be concerned about this current pandemic for those who've been infected? Well, many of you will have heard of encephalitis lethargica, the strange neurological and neuropsychiatric disorder that affected tens of thousands of people around the world, starting in 1917, but affecting those individuals decades later. It's got an interesting and controversial relationship to the 1918 influenza pandemic, the Spanish flu. Lots of people have linked them temporally. And it does seem like a disorder like encephalitis lethargica that suddenly appeared and then we've never seen it since must be linked in some way to an infectious outbreak. But the evidence linking it to Spanish flu is actually rather weak in that encephalitis lethargica, the first cases were reported before the outbreak of Spanish flu. And we've never managed even in recent studies looking at post-mortem material from EL infected individuals to find the Spanish flu PCR in these individuals. But I think it's likely that, that there must have been an infective trigger for it. And it was probably, rather than a direct effect of the virus, it was an immunological response that caused these neuropsychiatric sequelae, specifically Parkinsonism, psychotic features, and catatonia. The psychological impact on those who are affected is enormous. There's the effect of having a severe illness. There's the mass anxiety, the fact that the media is telling you that this is a serious illness and it's a life-threatening pandemic. During the pandemic, I went back to clinical work for a couple of months where I was working in a busy consultation liaison team. And I was seeing patients who were clinically getting better from their COVID, but in many cases were still terrified that they were going to die. We had people pulling off their oxygen masks because they believed that they were going to die anyway. One or two people are trying to end their lives within hospital because they thought it was all futile. There's the isolation, which is a little bit different to many other illnesses. The way in which patients weren't allowed to have their relatives visiting them. There were difficulties communicating with staff, often through 2 or 3 layers of plastic. And obviously there are employment and financial difficulties when patients are discharged from hospital. There's also the iatrogenic impact. So just being in ITU is a traumatic and difficult experience. And there's a lengthy, there's a large amount of research on delirium in ITU and PTSD following it. Because of the number of people who were in intensive care during the pandemic, in many countries in the world, intensive care units had to change their practice. So this included having staff who wouldn't usually work in ITU, but also using different agents. First line agent for sedation is often propofol. Supplies of this ran short, certainly in the UK, and I think in many other countries. So often intensivists were resorting to other agents like midazolam, which are associated with more confusion and more amnesia. And then there's the impact of corticosteroid prescription, which is becoming more and more an issue since the recovery trial showed that dexamethasone reduces mortality by about a third in patients with severe COVID-19. And we'll come back to that. Does SARS-CoV-2 affect the CNS? It's a question that there's been a lot of speculation about, and probably more speculation than evidence. One early paper from Ling Mao came out of Wuhan in the pandemic and looked at 200 odd patients who'd been admitted with COVID-19. And they had this headline figure, which made the press, saying that 36% had neurological manifestations, which is obviously very stark and very concerning. When you drill down into these, though, you see that a lot of them are manifestations of systemic illness, so dizziness, headache, for instance, and they don't necessarily imply neurological involvement of the virus. Impaired consciousness occurring at about 7.5%, and this anosmia, which when it was assessed systematically, occurred much more commonly. Even anosmia, though, the weight of the evidence seems to be shifting more towards this being not a direct neuronal involvement, but probably more involvement of the nasal mucosa. They did find some interesting associations with having these neurological symptoms, notably being older, having more comorbidity, and having fewer typical COVID symptoms. In theory, there are a number of ways in which the SARS-CoV-2 virus could invade the central nervous system. It enters cells via the angiotensin converting enzyme 2 receptor, which is expressed in neurons, microglia, astrocytes, and also the myelinating oligodendrocytes. And there are some plausible routes of entry, so it could pass transsynaptically, nerve, there could be infection of the vascular endothelium, or there could be this white cell migration across the blood-brain barrier. However, this review in JAMA Neurology over the summer said that although there are reports of neurological complications in patients with COVID-19, it's unclear if SARS-CoV-2 is neurotropic in humans. And I saw a paper just yesterday looking at the CSF of patients with SARS-CoV-2 who died, and not a single one had a PCR for the virus in the CSF. So if the virus is infecting, if the virus is causing a neuropsychiatric impact, either it's very rare and we're not seeing many of these patients, or it's doing it indirectly. Rather than the virus itself infecting neurons, there's some other mechanism. So we did a systematic search of the literature. We searched various databases, and we also took the decision to include preprint servers because the literature is developing so rapidly. We looked for patients with suspected or confirmed coronavirus infections and any psychiatric or neuropsychiatric complications. And we had this cutoff back in April, which is an awful long time ago in this field. We initially identified 2,500 articles, and in a frenetic couple of weeks, during which I think none of us slept very much, we whittled it down to 72, which we included in a narrative summary, and then 7 made it into a meta-analysis. I'll focus first on the acute impact of these viruses. when we look at the qualitative data from SARS and MERS, we were in two minds whether to include this, but I found giving talks, often it was actually what I was asked most about, because it was really quite intriguing. So patients talked about loneliness, boredom, frustration. Lots of people were very concerned about infecting family members. But actually in the acute phase, and this distinguished it a little bit from the follow-up, there was a lot of gratitude for the support that they'd received, and a lot of appreciation. In terms of the symptoms that people experienced, insomnia, anxiety, depressed mood were very common, which for those of us with the experience of working in a general hospital will ring bells as being just frequent symptoms that we see in a lot of our patients. What was a little bit more surprising though was slightly less common symptoms of pressured speech, euphoria, aggression, irritability, in a small minority of patients, but still quite interestingly. Importantly, these were subjective self-report symptoms from patients. So they might not meet the definitions that we as mental health clinicians would give them. But I think these symptoms make a little bit more sense when you have a look at some of the other symptoms that these patients are experiencing, which I missed off the previous slide. So almost 30–40% were experiencing poor concentration, impaired memory, confusion, emotional lability, and 1 in 5 were experiencing altered consciousness. Altogether, these look very much like hallmarks of delirium. And this seemed to be the headline neuropsychiatric impact in the acute phase for patients with SARS and MERS. In terms of other psychiatric diagnoses, again, it was just a few case series in the acute phase, a couple of cases of depression, anxiety, the kind of things that are very common in consultation liaison psychiatry. What was quite interesting was 16 cases of psychotic disorders, 15 of which were analysed in one study and accounted for about 1% of the total cases of SARS. This study here compared these 15 cases with psychosis to 30 age and sex match SARS control patients. 13 out of the 15 have been diagnosed by a psychiatrist with a steroid-induced mania or psychosis. And this, I think, is where SARS can actually still teach us quite a lot for the direction that COVID is taking, because early in the COVID-19 pandemic, there was this idea that steroids might be unhelpful and might increase mortality. But I think in the second wave, we're going to see a lot more dexamethasone, prednisolone, and hydrocortisone prescribed. Sorry, would you mind just muting your mic?
Petra? Thank you.
There are a couple of risk factors for psychosis. Higher cumulative corticosteroid use was one, which fits with the steroid-induced mania or psychosis hypothesis. But actually, the difference wasn't that big between the people who didn't develop psychosis and those who did. But actually, having a family history of psychiatric disorder was much more common in the people who developed psychosis. Now, these are small numbers, but it suggests that steroids weren't just the only factor, and some of our biopsychosocial formulations are actually going to be quite useful in these people. And I think we'll be seeing more of this in the next few months as dexamethasone is used. What about delirium in COVID-19? Two earlier studies in the pandemic systematically assessed neuropsychiatric symptoms. And there was one in France, which looked at ITU patients after extubation and found that the majority had agitation, most of them had confusion. Of course, ITU patients are the most severely unwell, and there are big iatrogenic effects here. But it was quite interesting that even at discharge, 5 out of 45 had a dysexecutive syndrome, characterized by inattention and disorientation. There was then another study from Wuhan, 82 patients who subsequently died. So again, the most severely unwell, and 17 out of 82 had altered consciousness of some sort, ranging from delirium to coma. And other studies have reported confusion, not very systematically, in between 2 and 22%. We do now have data on larger numbers, and this study by Doherty et al. In the BMJ, published a couple of months ago, had a look at the hospital records of 20,000 patients hospitalized with COVID-19. Now, importantly, these were routine care records, and we know that delirium is underdiagnosed and under-recognized by clinicians. But they found that in about 20 to 25% of patients, confusion was occurring. And that was the 5th most common symptom after cough, fever, dyspnea, and fatigue. So more commonly reported than cough, diarrhea, nausea, and vomiting. It's actually one of the most important symptoms in these individuals. The next question is, we know that delirium is common in COVID-19, but can delirium actually be the presenting feature of COVID-19? And this study, published a couple of weeks ago by an Italian group in eClinical Medicine, had a look at a group of elderly patients in a residential home with confirmed COVID-19. They found that in 21 of these patients, so 36%, they had delirium onset COVID-19, which they defined as mental status changes being the only presenting feature. So they didn't have any respiratory symptoms. And this is enormous. I wonder if partly this is because these patients had dementia, and so they were particularly vulnerable to any cognitive impact of COVID-19. But I also wonder slightly skeptically if these patients were less able to report symptoms like shortness of breath or cough than other patients. But it does look like delirium onset COVID-19 is possible. It didn't seem to have a particular hallmark, distinguishing it from delirium with other causes. So there were a mixture of hypo and hyperactive features. But I think it does show us that COVID-19 needs to be on our differential diagnosis for confused patients we see. Does it have any significance? Well, this study, although it was small, seems to suggest that it did. So the delirium onset COVID-19 was associated with a much higher mortality with an odds ratio of 17. Now, this had a wide confidence interval, but even if the true value is anything like 17, this shows that patients with delirium and COVID-19 really are a very vulnerable group who we need to be advocating for and identifying. CoroNerve is a surveillance study which has been running since the early part of the pandemic. And the idea of this was, rather than getting representative cases of COVID-19, it was to pick up the weird and wonderful, the neurological and neuropsychiatric impact of COVID-19 infections. And of course, this results in a substantial reporting bias, but it does mean that some of the more interesting presentations are picked up. The headline figure is that 62% of these 153 cases were stroke. And other evidence has showed that SARS-CoV-2 infection does increase the coagulability of the blood and does increase the risk of ischemic stroke, even compared to other respiratory infections. But one interesting story behind this paper was that it was initially submitted to Lancet Neurology, and it was actually bounced to Lancet Psychiatry. Apologies, it's not JAMA Psychiatry, because one of the most interesting findings was that altered mental status largely did, which was often delirium, but not exclusively, was so prominent. So there's this encephalopathy, which is often the term that neurologists will use for delirium, encephalitis, and psychiatric diagnoses. There are a number of cases of psychosis, some neurocognitive syndromes, some of which were new onset, some of which were worsening of existing syndromes, and some affective disorders as well. I think we've got to be really careful with this kind of evidence, though. And an analogy I give is Guillain-Barré syndrome, which is a severe neuromuscular disorder. And for the last few months, I worked with quite a lot of neurologists, and the neurology world has been getting very excited about the connection between COVID-19 and Guillain-Barré syndrome. A number of cases have been reported of COVID patients who've developed this. And there have been systematic reviews of the cases. When one of my colleagues, Stephen Keddy at UCL, had a look at big data of Guillain-Barré syndrome and COVID-19, they actually found that Guillain-Barré has been less common during the pandemic period than during the same months in the 3 previous years. There's been no correlation between COVID-19 and GBS incidence, and no difference in clinical presentations. They even speculate that the fact that we're all in isolation now means that the enteric bacteria that are usually associated with Guillain-Barré syndrome aren't spreading as much. So actually we're getting fewer numbers. So I think we've got to be careful in interpreting this case series type data. So key points in the acute phase: there's enormous stress having an acute infection. Delirium is very common and may be a presenting feature in the elderly. And these specific neuropsychiatric syndromes are probably rare. What about post-illness impact? And I'm going to really focus on these SARS and MERS data because actually the long COVID story has broken in the popular media much earlier than it's broken in the peer review literature. To those of us who were familiar with the SARS and MERS literature though, long COVID wasn't any surprise at all. So when we look at those studies that reported acute symptoms and we follow those patients up, we found that a slightly different pattern emerges. The common symptoms seem to be fatigue in about 20%, this frequent recall of traumatic memories. Interestingly, a number still reporting emotional lability and these subjective cognitive symptoms, so impaired memory, impaired concentration. We did a meta-analysis of psychiatric disorders in the aftermath of SARS, and we found that anxiety disorders occurred in about 15% of patients who'd had SARS. And the follow-up time, some of the studies were just 3 months, but there was one that followed patients up to 2.5 years later. And the prevalence of these disorders didn't really seem to change. Now, the caveat is, of course, that anxiety is a common disorder, and we don't know how many patients had it before SARS, and we also don't know how many would have developed it anyway. The figures for depression were very similar. Again, about 15% of patients who had SARS at a reasonably long follow-up period were still experiencing depression. What really struck us though, and we weren't quite expecting, was the figures for PTSD. And this gave a much higher rate of about 32% of people who'd had SARS were experiencing PTSD. And this was months, even 3 or 4 years later. So I think as psychiatric services, we really need to be prepared for this. When we looked at continuous measures of distress, such as the HADS, the Hospital Anxiety and Depression Scale, we found that the average was below the clinical cutoff, but still seemed concerning. In terms of quality of life, a couple of studies used the SF-36. For those of you who aren't familiar with it, it's a quality of life scale ranging from 0 to 100 with several subscales, and there's population normative data. For the purposes of mental health, there were 3 subscales that are of particular interest. There's social functioning, there's role limitation to emotional problems, and there's mental health itself. When you look at social function, relative to the Hong Kong normative population, those post-SARS had 25 points fewer, which out of 100 really is quite significant. In terms of the role limitation due to emotional problems, they had 15 points fewer. And when we look at the mental health, they had 10 points fewer, which is interesting for a couple of reasons. Firstly, it shows that patients with SARS at follow-up did seem to be having a poorer quality of life. but I think it's probably fair to say that it doesn't seem to be a specific effect on mental health. And if anything, the global function effect, the social function and the physical limitation actually seem to be bigger than the specific effect on mental health, which maybe means that some of those symptoms, like fatigue or subjective cognitive problems, are accounting for more of the issues rather than, say, traditional psychiatric symptoms such as low mood or anxiety. In terms of employment, at a 3-year follow-up, 3/4 of patients had returned to work, but that still left 1/4 who hadn't, which I think has enormous ramifications given the number of people who've been infected with COVID-19. So what are the implications of this? Let me just get to where I was. Well, I think the studies so far have got a lot of limitations, and looking at lots of the COVID-19 literature, some of the same problems seem to be emerging. So there have been lack of control groups, which means it's very hard to say what are effects of being infected and what are some of the more non-specific effects of being subject to a pandemic. There's been a lack of data on pre-morbid mental health, so we don't know how many people had psychosis before these studies began. There's lots of reporting bias in these studies, particularly the case series type studies. And there's a lot of, and the vast majority of data, well, pretty much all the data in SARS and MERS was on patients who've been hospitalized. And we're seeing exactly the same thing with COVID-19, and that it's easiest to verify an infection in people who are admitted to hospital because they're all tested. And it's easiest to recruit them because you've got them in one place, you've got your hospital records to follow them up with. What we're really not seeing is data on people who aren't hospitalized with COVID-19, who have a milder illness. And of course, this accounts for the vast majority of people who are infected, particularly among those who aren't elderly. I think when we're thinking about long COVID, we really need to be bearing in mind this milder infection population. In terms of the comparability, we do need to be a bit cautious when extrapolating information from SARS and MERS. The mortality varies substantially. It's much higher for both of those illnesses than it is for COVID-19. Although actually the ICU admission rate was very similar. So SARS patients who were admitted to hospital, 13% of them went to ITU. COVID-19 has been 18%. So among the hospitalized population, maybe there's a bit more that we can draw. I think delirium is massive and is underappreciated within hospitals and in the public discourse about COVID-19. I think delirium itself is sometimes hard to diagnose, but it also leads to difficulties diagnosing other illnesses because patients can't talk about their symptoms and will even struggle to be examined. Delirium is also associated with, on average, 7 days extra in hospital, which has implications for our health services as we try to discharge people so that we can admit new people during a pandemic. It's associated with a protracted recovery and often a drop in baseline cognitive function in those people with pre-existing dementia. And one issue which we faced clinically was around mental capacity and ceilings of care. There was a lot of discussion during the height of the pandemic about which patients should be escalated to ITU, high dependency units, cardiopulmonary resuscitation. And often these discussions were had with patients in quite a rapid and hurried manner when they were admitted to hospital. And we found sometimes that patients who had been assumed to have capacity to have these discussions, when we spoke to them, they didn't know where they were, they didn't know that they were unwell, they didn't realize they were being treated in hospital. So actually they completely lacked capacity for these discussions about ceiling of care. So I think assessment of delirium needs to precede these difficult discussions. What about the implications for follow-up? Many guidelines around the world, including the British Thoracic Society in the UK, recommend asking about psychosocial status at follow-up, which I think is helpful. I think the kind of things that primary care physicians and hospital physicians, this is intensivist respiratory physicians and infectious disease physicians in particular, who will be seeing these patients as outpatients, will need to be aware of depression, anxiety, PTSD, and this chronic fatigue. If you recall earlier, it was 20% of SARS patients were reporting fatigue in the follow-up period. I think we'll also need to be looking at cognitive problems. The evidence for subjective cognitive impairment has been around for a while, but we're just starting to get some early evidence that there might be some objective cognitive impairment in patients who've had COVID-19. I think some difficult issues to work through in mental health services will be how we assess cognition in these patients, how we treat them. Often older adult services are well set up to cope with cognitive impairments, but services for working age adults and children and adolescents, it's not something that they've really had to deal with. I think we also need to think about whether there's any follow-up that's necessary for those who have minor infections that may or may not have been tested and diagnosed. If you want further information, this is our paper in Lancet Psychiatry. If you don't fancy a long read, we've also made a video abstract in the form of a song, which you can find on YouTube. So have a look at that. So in conclusion, delirium is really common in patients who are hospitalized for COVID-19. Depression, anxiety, and PTSD are likely to be really significant in the follow-up period, and I think particularly PTSD will be the one that stands out. Specific neuropsychiatric syndromes, that the rare and wonderful, will probably still be rare and wonderful, although encephalitis lethargica teaches us that sometimes the impact of a pandemic can only be seen years or decades later. And the good news is that we can reassure our patients is that most patients will not have a mental illness, even after severe COVID-19. Thank you so much.
Oh, I'm on mute now. Thank you. I was trying busily to unmute myself. No, the host. Great. Thank you, Nora. Jonathan, before we start on the serious questions, you're not going to give us any little song or a little rendition of the music clip?
Sadly, my piano is downstairs. Otherwise, yeah.
You're very lucky. You're very lucky. I just wanted to start off. I was listening to a podcast, which is, I must say, where I'm finding very, very useful information from all around the world, up to date, often ahead of publications. And there was one podcast, I think it was from an international group, 4 different countries, but there was a group from Sydney, both a neuropsychologist and a neurologist, and actually part of the issue was, do you call it encephalopathy or do you call it delirium? And what they took, you mentioned a little bit that some of the reservations are that the neuropsychiatry aspects are coming within those that are severely ill with COVID, which is a much smaller minority. And then that group of severely ill COVID infective individuals, COVID infected but not ill, and then kind of community-based larger, that the symptom of anosmia was actually linked with cognitive abnormalities when they tested both of them formally. And they were using that as an argument for that actually they do believe that this virus is neurotropic. And it was independent of the severity of the COVID symptoms. So I just wondered, I mean, it is surprising that there isn't any evidence of CSF, remnants of COVID or indication of actual CNS pathology. And what I'm taking from your talk is that really most of the neuropsychiatry relationships is both kind of maybe more non-specific and more general depression, anxiety, PTSD. Do you think if there was more evidence of cognitive abnormalities linked with this anosmia and lack of taste in some cases, do you think that would argue for direct effect of the virus on the nerves and maybe migration, into the brain and the meninges?
Yeah, thank you. I think that's a fascinating question, a fascinating debate. So in vitro, it's possible to infect neurons with SARS-CoV-2. It's just, as you say, there's very little evidence in vivo at the moment. I think one explanation that could account for the cognitive symptoms and also the relationship with anosmia is not so much the direct effect of viral invasion, but is an inflammatory response, which would explain why anti-inflammatories like dexamethasone are showing evidence in COVID-19, in that the host immune response is just disproportionate and unhelpful. And this seems to be accounting for the very small number of cases where children become seriously unwell with COVID-19. They have a severe and dysregulated inflammatory response. I think that's probably more likely to be mediating the biological effect than the virus.
Which maybe is reassuring in some ways. There was a question by one of our attendees, Victor Oanka, I hope I've pronounced your name correctly, one of our trainees from Romania, and he was reminding us of in encephalitis lethargica, there was a significant number of children that had ADHD-like symptoms. And he was wondering whether there's any, you mentioned a little bit about some of the symptomatology in children. Unfortunately, it is very rare. But is there anything coming out to suggest either in the adult or child literature any increase in ADHD, or maybe, again, it's not being looked for?
So it's an absolutely fascinating question. I haven't seen any data on it. Certainly it wasn't looked at all during SARS and MERS, and I haven't seen anything during COVID-19. So more of the literature with children and adolescents seems to have focused on individuals who've been quarantined. So there's been an infection in a hospital, and individuals are kept in their rooms in a pediatric ward type thing, rather than being infected. It's an important area.
There was another question I had in terms of, there's a huge amount, I mean, there's the direct impact of the virus itself, in invading or being involved in pathology of the brain. And then the indirect effects you mentioned, like treatment effects, other effects, the environment of the delirium, and maybe even interaction with various medications. Do you think in some ways that more attention needs to be considered about that? I mean, obviously the whole focus is very quickly treating the COVID itself. But do you think there is sufficient awareness of the secondary impact in infected patients of increasing psychological distress? In the same way now they're beginning to recognize in the ICUs that there is a need to expect PTSD post ICU admission, and part of the post ICU step down treatment, is screening for that and then managing that.
I think that's.
I was going to say, how well are people actually screening for these psychiatric or psychological consequences in the COVID patients?
Yeah, I think this is a huge issue and will become a big story in the next few months. One thing I didn't include in this presentation was the qualitative literature long-term for SARS survivors. And there they said that they were still getting, that their overarching message was, we got great care when we were acutely unwell, we had loads of attention, and now we've still got loads of symptoms. We get lots of stigma. We're not allowed to attend the same clinics as other patients because of fear of infecting them. And doctors don't believe our symptoms. We still got all these problems, but we don't have the virus in our in our system. So doctors are saying that these symptoms aren't real. And I think there's a real danger that we do the same thing with COVID-19 and become dismissive of these longer term symptoms that people are experiencing. In terms of screening, I think it's a difficult debate. There's certainly a debate about whether it's advisable to screen for PTSD post ITU, and on the one extreme, we don't want to go down the route of psychological debriefing after traumatic events, which increases risks of PTSD. On the other hand, I fear that at the moment, many of these patients aren't just not getting any psychiatric follow-up. I think they're often not getting any follow-up at all. So there isn't even the opportunity for an observant general practitioner to see that they're much tighter than they were before. They're not managing to get out of the door. They're not managing to do their jobs in the same way. So I think at the very least, some kind of informal screening is necessary.
And in the longitudinal follow-ups of COVID positive patients, I know that some people fought hard and included some psychiatry questions. I'm not aware, I haven't looked at or read anything about what sort of questions they are. Are you familiar at all, Jonathan, with what sort of questions? I mean, I guess it's to tease out, or to try and help us tease out, the difference between specific psychiatric neuropsychiatry presentations as opposed to more non-specific reactions to the illness and, you know, restrictions, etc. You're not familiar with what they've included in those long-term follow-ups.
Yeah, so I'm slightly linked with one follow-up study being led out of King's College London, and we have managed to include some of the more standard psychiatric rating scales, so the PHQ-9 for depression, the GAD-7 for anxiety. The other ones we've managed to get in have been fatigue, using the Cholder chronic fatigue scale. And I have managed to get a catatonia scale in as well. But yes, as you say, how specific these are for the neuropsychiatric effects of COVID is probably not very strong. Right.
And of course, the much larger problem is the natural response to COVID, the anxieties, the psychological presentations that you had mentioned. And again, if you tease that out into two groups, you have a group with pre-existing mental illness and those that haven't ever had any mental health problems. Can you say a little bit, if you are familiar, has anybody looked at that and, you know, kind of come up with, because I guess as psychiatrists working, part of what we need to do is, if there are risk factors in our current caseloads of actually an escalation of problems, it may be that there's something that we can preemptively do about that ahead of time. But for that, it would be nice to know if there are certain risks that are going to help us determine where we should be putting our preventative actions.
Yeah, that's a really important question. So there was some literature, there were a few studies looking at this in SARS in the longer term, and some of the risk factors were the kind of things that we're very familiar with in mental health. So some of the risk factors that just predict psychopathology. So women were at higher risk, people with a prior mental disorder were at higher risk, and those with lower psychological resilience are at higher risk. One or two of the factors were disease related. So having a more severe illness, and being more disconnected from family seem to be big factors. There's a study I peer reviewed just in the last couple of weeks, which suggested a very similar thing. But I think there'll be one or two things that were less expected as well. So medico-legal involvement. Active medico-legal involvement was associated with poorer psychological outcome, which is very difficult for us as clinicians how to advise patients, where if they do have problems with the care that they've received, how to address that without damaging their own mental health.
Mm-hmm. There's something wrong with my mouse, apologies, so I can't send an individual chat response. But Emmett, I was reading your question here, and I'm just going to say it out, but I was wondering if you had wanted to speak to it at all just before I read out your comment. And unfortunately, I can't send you a private chat to ask you that ahead of time. Emmett, are you still on board? Would you like to talk to the conference you were at? Okay, so it may be, I'll just read out what was said here, that Emmett Power was at a conference, a GUI conference yesterday, and the keynote indicated that they would be publishing a report on the COVID follow-up of the Millennium Cohort study in November. Jonathan, you might be familiar with that yourself. That would allow some inference in the change of rates of psychopathology in young people during COVID. And I guess, that might attest a little bit more to the biological nature of it. And GUI will be doing some sort of work as well. Oh, Nora, would you mind unmuting Emmett? There seems to be something wrong with our ability. And maybe he... Great. But thank you. Calling on you like that.
Oh, no, it's okay. I was at the Growing Up in Ireland conference yesterday, and the keynote speaker was Prof. Emla Fitzsimons, who's the director of the Millennium Cohort study. And I guess they have been doing like a COVID follow-up questionnaire of their longitudinal work on the Millennium Cohort study. So I guess that would allow some inference of like, has there been rates of change in psychopathology in, I guess, community, in a representative community sample of young people during the time of COVID. And I guess she didn't give any kind of indication as to what the results would be, but that they would be kind of publishing their initial report in November. And I think that the minister opened the conference yesterday, and he also indicated that he's asked the Growing Up in Ireland team about whether they'd be kind of doing a COVID specific follow-up of young people in Ireland during the time of COVID. I guess that would kind of allow us to make maybe more informed decisions about, how COVID is affecting young people, and I guess how the change in society has affected young people's lives. I guess that has the benefit over maybe cross-sectional work that's been kind of done to date of knowing who the young people were before they were, or knowing lots about the young people kind of before COVID as well.
That sounds incredibly valuable. Even lots of the cohort studies that are being that I've come across have started their follow-up during the pandemic, so you've got no idea of the difference from before. So being part of an existing cohort study sounds like a much better design.
I guess, Emmett, it would be really important in that study, they would ask whether they have been COVID positive or not, and also try in some ways have some measure of the proximity to COVID cases. Obviously the lockdown, the restriction, we're back there again. There's a there's a mixed sense, I think, of complacency, but also a sense of, apathy, depression, disillusionment in a group. And understandably, that will have a huge negative impact, we expect as well. But the real risk of infection for some people with elderly parents or ill parents or those that have had COVID will bring an additional stressor. And I guess if you don't measure that, you're going to lose that signal. So hopefully they will also, in addition to, getting some sort of information about general psychopathology, they might look specifically at COVID status and, proximity, to COVID status within a household. Certainly, Jonathan, by way of the frontline workers, one of the biggest risks of psychological ill health or distress is the anxiety about infection to yourself, but transmission to family members. And the higher rate of psychological distress was found in those healthcare workers that had family, which normally would be a protective effect, but actually in these pandemics is turning out to be a risk factor. And that's because we're worried about going home and infecting people before we know it. Yeah.
That's fascinating.
with testing becoming much more easy. I mean, it's amazing how many healthcare workers have been tested 5 or 6 times that are not even necessarily in the very front line. But with the increase in testing, I guess it should reassure us that at least if you're nervous about a cough or a cold or a sniffle, you know, very quickly you're able to get tested and not have to stay off work unnecessarily. I'm going to read out another question, and apologies, I don't think I can use my chat. I'll have to check that up. A question or a comment from Dr. Aisling Mulligan, Professor Aisling Mulligan. We did a small study on children's mental health in COVID era in North Dublin and found no change in emotional well-being in the school group in 2020 versus 2019. And that was a poster presentation by, I'm guessing, an SSRA medical student. Congratulations, C. Gilligan. Same school, but only 20% response rate in 2020. So I guess, Aisling, again, I don't know if you'd like to speculate about any respondent bias in that sample and tell us a little bit more about your method. Great, thank you.
Yeah, we distributed a form to a complete school in 2019, in June of 2019. Now, it was the My Feelings form, a new form we were developing on emotional well-being. But when the pandemic came along, we decided to distribute it again to the same school in 2020, June 2020. Now, it's actually 25% response rate. I just have the poster in front of me here. So what we can say is that the 25% of young people who responded by postal survey in 2020 indicated the same emotional well-being as the complete school did in 2019. So for those who responded, there was no change in emotional well-being. But of course, I can't comment on the 75% for whom we have no response rate. So,
and when did you carry out that study? What was the
June 2019 and June 2020, and then it was presented just mid-September there at the UCD Summer Student Awards, the poster awards. So it's yet to be published.
Did it include or exclude the Leaving Cert cohort?
No, sorry, I should have clarified. It was a primary school group. Okay, so and it was, we actually just studied 3rd class to 6th class of a complete primary school. In 2019, we had a complete primary school from, I think we had the complete primary school, but we only actually analysed the data from 1st class up. And in the 2020 group, we have 3rd class to 6th class.
Right. And within your results, how many people were scoring? I know it's a small, I mean, 25%. How many people would that equate to?
Wait till I just see how many we had back. I think we had about 60 or 70 of them back. 60 forms were returned. 60 forms, yeah.
And what was there within that cohort the expected number, you know, like the 10% that actually scored within the pathological stage? Yeah,
we had, well, it was a new form we were developing, the My Feelings form, a kind of a colourful cartoon-based form. And I was actually quite alarmed. The first year I sent it out, 2019, there were a group of children who definitely scored much higher than others. So there was a small group that were higher. I'm actually going to show the camera the 2019 versus 2020 data if I can. It just maps perfectly. Yeah.
Aisling, we won't have time for
won't do that. Okay. Okay.
That our next, thank you.
Okay. Yeah.
Our next talk, bring it to our next talk next week.
Okay. Yes. Yeah. Certainly. Yeah. Thanks.
Next week we're having a specific seminar on child mental health and COVID next week.
Okay, certainly. Yeah.
Harold, who's coming from Cambridge.
Yeah.
And I'm going to wrap up. I'm going to wrap up today really quickly. Jonathan, thank you so much for an excellent presentation. It was really, really fantastic to hear a little bit of reassurance perhaps from the neuropsychiatry aspect, but that doesn't take away from the huge secondary impact that both the infection and the restrictions and societal change is bringing to us. Could I welcome everybody to next week's session, Professor Harold, as I mentioned, on supporting children's mental health. The week after that, we're having Professor Benrose, which is on November the 6th. And it ties in very much with Jonathan's presentation. We're looking at immunology and COVID. That's next week. The following one, Nora, is then our neurodiversity conference that we're having on the 3rd and the 4th of December. So we'd welcome all of you to have a look at that. Immediately following this, we're delighted to say we're moving straight into the special issue of the medicine. And so for those of you that are able to continue with us, please stay on board.